Hi, good day, dear colleagues. This is Dr. Jihad, and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know, and today we are going to talk about anal intraepithelial neoplasia. In some sources, surgical sources, you will find this lecture under the title Anal Cancer Screening. As we will see in the next few minutes, that anal epithelial neoplasia is the precursor or the pre-malignant condition that will lead to anal cancer in some degree. To give you just a hit to understand what does anal intraepithelial neoplasia mean, I think that most of you heard about the pap smear that the gynecologist do for screening for cervical cancer, and he can catch cervical intraepithelial neoplasia. It is the similar concept in gynecology in the colorectal or in the anal region. So in anal intraepithelial neoplasia, we are screening for the pre-cancer condition, pre-malignant condition that would lead to anal cancer. As you see, it is a pre-malignant stage for anal cancer, and it mirrors the finding, even the information we have about anal intraepithelial neoplasia, most are from the gynecological sources, because it mirrored the cervical dysplasia in female. We will see that the cytology is useful, especially for screening in high risk group, and we can go further up in the screening by using high resolution anoscopy. We will see what does high resolution anoscopy mean, and the different modality of treatment. If we catch these pre-malignant condition, what we should do? Should we observe? Should we proceed for ablation? Should we do surgery? We will see that this actually depends on many factors, depends on the degree of dysplasia, the risk factor of the patient, and the immune status of the patient, the symptoms, and the likelihood of a progression from anal intraepithelial neoplasia to cancer, because not all intraepithelial neoplasia will develop to cancer condition. Actually, one of the, let's say, dilemma that face us, that we have accepted national screening program for cervical intraepithelial neoplasia, but anal intraepithelial neoplasia, unfortunately, we have not. It depends on the surgeon experience and etc. Okay. Again, anal intraepithelial neoplasia is defined as the growth of dysplastic cell in the transition zone in the anal canal. As you remember from the anal canal cancer, that the transition zone is the source of the carcinogenic cell that will develop later to squamous cancer. And we know that this transition zone share the same embryological, cytological and histopathological characteristic with cervical canal. And as we said, most of our information, most of our classification are drawn from the gynecological sources. We have association, and this will guide my screening. We have association between anal intraepithelial neoplasia and a human papilloma virus with HIV virus, male who have sex with male, and those who have organ transplant, immunocompromised. Okay, we have actually three classification systems that we should know. Regarding the grade, we have anal intraepithelial neoplasia grade 1, which is mild dysplasia, grade 2 moderate dysplasia, grade 3 severe dysplasia. Actually, the dysplasia cytologically is determined by the nuclear cytology ratio. The smaller the nucleus, the bigger the cytology, so the severity of the neoplasia will be higher. This is one. Two is classified, as you see in front of you, to low-grade squamous intraepithelial lesion. This is if we have human papilloma virus related lesion. It could be low grade or high grade. When we say low grade, this is anal epithelial neoplasia grade 1, or simply it is condyloma. It is mild dysplasia. If we say high grade squamous intraepithelial lesion, mostly associated with human papilloma virus, this is grade 2 or grade 3. Another cytological classification is anal intraepithelial neoplasia A, B, C, D. C and D stands for low grade squamous intraepithelial and high grade intraepithelial neoplasia. A is of undetermined significance, B that cannot be ruled out. As you see in this picture, cytologically we have anal intraepithelial neoplasia A, which is atypical and of undetermined significance. B is atypical, we cannot rule out high grade. C and D, this is low and high grade squamous intraepithelial neoplasia. Okay, the incidence actually is unknown, and we have to remember that low squamous intraepithelial neoplasia can progress to high grade squamous intraepithelial neoplasia, or it may regress. This depends actually on the immune status of the patient. Does the patient have another risk factor? For example, he is HIV, male to male, a male who have sex with male, MSM patient. The higher risk for conversion from low grade to high grade and developing cancer is those patients who is HIV positive with who have sex with male. This is the higher incidence. What else we want to add, that about 20% of women who have genital intraepithelial neoplasia, such as cervical, vaginal, valvular neoplasia, will have a degree of anal epithelial neoplasia. So there is association, and we will see that in patient who we detect anal intraepithelial neoplasia, we should refer them to gynecologist for further screening for genital intraepithelial neoplasia, and vice versa actually. What else? Actually, what we know is about 15% of the patient with high grade or anal intraepithelial neoplasia grade 3 will develop to anal cancer. What else we didn't add? The rate of high intraepithelial neoplasia is increasing due to the screening protocol. Higher risk with HIV positive male who have sex with male. The incidence is unknown. Okay. Epidemiology. We have to remember that anal intraepithelial neoplasia develop from human papilloma virus contact, HPV, with direct contact, direct exposure. And this will lead us to talk a little bit about HPV infection. Okay. Actually, the HPV infection can be in 4 variants. It can be subclinical, as you see here. It can be grossly apparent, such as condyloma. It could be only microscopically apparent, or latent. The infection will appear after years of infection. Actually, the disease progression from subclinical apparent to grossly clinical depends on the immune status of the patient. And this is a nice information that there is a potential to migrate from the genitalia from the cervix, from the valvular system, valvular to the anus. And these are risk factors that determine the immune status of the patient. For example, patient with high risk factor, these are uncircumcised men, and men who have sex with men, multiple number of previous sexual partner, sex with partner who have many previous partner, early first sexual contact. One of the nice information that we have to remember that approximately all sexually active female and male will develop HPV virus in their life. But if they are immunocompetent without a treatment, it will regress and disappear within 2 years. As you see here, we have many serotypes for HPV, more than 150 serotype. Of these, the high risk serotype is 16 and 18. These are responsible for 80% of squamous cell carcinoma. We have other high risk, 31, 33, 35, 45, and these high risk serotype, what is unique for them, that they produce protein called E6 and E7, which finally will inhibit the P53 and RP retinoblastoma protein. These are tumor marker, tumor suppressor. They will inhibit them. Of the low risk serotype is 6 and E11. These are low risk, and 90% they are responsible for the genital warts in 90%. The vaccine for HPV appears in 2060 and lead to decreased in the on the high risk and the low risk serotype. As you see, the human papilloma virus 6 and 11 the low risk, and 16 and 18 the high risk, decreases in 50% in teen and woman. Okay, let's go a little bit back. I want to discuss the risk factor. The risk factor for HPV infection include uncircumcised men, number of sexual partner, and sex with a partner who have many previous sexual partner, sex with uncircumcised men, and first sexual contact in the early life. These have a high risk. This may guide my screening actually, and you see that it totally depends on the immune status of the patient. Who to screen, how to do the screen, and the surveillance we will see in the next minutes. Okay, and actually the first question, who to screen for anal cancer or anal intraepithelial neoplasia, and how to follow this patient. And again, unfortunately, in anal cancer and anal intraepithelial neoplasia, our study is retrospective. Most of our guideline is from the gynecological sources regarding cervical intraepithelial neoplasia. We have, even in America, there are no national screening program for anal cancer, and this will reflect that we have no sufficient data for which patient to screen. But generally we can say that those patients with high risk, such as male who have risk with male, HIV positive patient, immunosuppressed patient, woman with a previous history of any genital malignancy, history of sexually transmitted disease, these patients with high risk for HPV infection, these should be screened. These should be screened. Okay, the screening come in 3 ways. Actually, it comes in digital rectal exam, or cytology, or anoscopy, or what we call it high definition anoscopy. We will understand what this means. HPV testing is not part of the screening actually. We are in HPV test, we just search for HPV infection, and we said that infection, HPV can be simply infection, not pre-cancer condition. So, three modality of screening. One of the important things that we have to remember that cytology should be taken before any any before digital rectal exam, before manipulation of the anus. And we have two methods to take cytology in anal canal cancer screening or anal screening. This is the liquid method and the solid method. We prefer the liquid method, as you see here. This is, we put actually anal cytology. This is the swab. We put it up to 3 to 4 centimeter in the anal canal, and we circumferentially move it, and we put it in a liquid media. It's better than the solid media because the solid media can obscure the field with fecal material, bacteria, air drying artifact, etc. Let's return here what we said. We said that cytology, liquid media is the preferred, and then digital rectal exam, and if needed, anoscopy. As you see here, the highest risk for anal intraepithelial neoplasia is HIV patient positive with male who have sex with male who have sex with male who is HIV positive. Okay, the cytological sensitivity is, sensitivity means to detect the disease 80% and specificity up to 40 patient. High risk patient need what we call it the high resolution anoscopy. Let's move here. This is what we mean by the high resolution anoscopy. Actually, why we do not proceed always to high resolution anoscopy? Because this will lead to a high population that will need high resolution anoscopy. So cytology can guide my treatment, my screening protocol. The result which will come back from cytology is divided to 3 or to 4 as you see here. This is after I take the anal cytology, I will have this scenario: either normal or insufficient or atypical squamous cell of undetermined significance, low squamous intraepithelial lesion, high squamous intraepithelial lesion, and squamous cell carcinoma. These are the results I will have in the cytology. Okay. And how, this is how the surveillance will be. If the result is normal, if the cytology is normal, this depends. Is the patient HIV positive or HIV negative? If it is normal and he is a high risk HIV positive, so we should repeat the anal cytology after 6 to 12 months. If normal and the patient is HIV negative, so we can repeat it after 1 year. Insufficient, we should repeat in 6 months. From anal squamous cell of undetermined significance and up, from here and up, low grade, high grade, and high grade require what we call the high resolution anoscopy, which we see it here. So it is only the normal that we can follow the patient, otherwise we have to proceed for high resolution anoscopy. And actually the result after the cytology, from this result I will go to high resolution anoscopy, and depends on what I see in the high resolution anoscopy. Is it normal or atypia? So I can repeat the high resolution anoscopy after 6 months. If it is low grade anal intraepithelial neoplasia, either I can follow or treat if symptomatic. Low grade can be symptomatic and can be asymptomatic. High grade should be treated, and if the cytology or the high resolution revealed squamous cell carcinoma, so should be treated accordingly. We know we should refer them to the hematologist for chemoradiotherapy. What else I want to add in this picture? Let's see what we didn't discuss. Okay, this is regarding the screening, how to screen these patients. This is a nice actual picture. So we start with anal cytology, digital rectal exam, high resolution anoscopy, and according to the result. Okay. Progression, we mean the transformation of anal intraepithelial neoplasia to squamous cell carcinoma. Again, unfortunately, most of our information is from the cervical CA in female. Actually, the human papilloma virus, it's like the viropioma, I think they are called. These viruses that changes the genotype, and ultimately this will reflect in the phenotype of the disease. As you see, there is a viral integration in the chromosome. They change some at the chromosomal level, in the chromosome 1, 3, 7, 8, 11, 15, 20, and we frequently noted that there is a gain in the long arm of chromosome 3 in anal cancer and also in cervical cancer. Viral genome, actually the virus, actually goes to the host DNA, which will cause cellular changes and atypia, and then the anal intraepithelial neoplasia appear. 1, 2, 3, up to squamous cell carcinoma, which is invasive. It is unclear if this sequence is mandatory or it can skip actually some steps. What we know that anal intraepithelial, we said that there is rule for regression. Cervical intraepithelial neoplasia up to 60% regress. You can see here 60% of cervical low-grade dysplasia will regress. The anal intraepithelial neoplasia is more resistant actually. Rarely regress. If it is low grade, it may regress. High grade, it will not regress. It may be latent for a long time, but it will not regress. As you see, more persistent than cervical intraepithelial neoplasia. Okay, let's go back. What else? Diagnosis. Okay, the diagnosis, we already discussed some information, but you can see here that anal intraepithelial neoplasia usually is asymptomatic up to low grade. Low grade intraepithelial neoplasia is asymptomatic, but can present with symptoms like pruritus, bleeding, irritation, tenesmus, pain. Of course, history and physical exam. And history, we should focus on HPV related disease such as oral cancer, gynecological diseases, etc. And exam should include inguinal lymph node exam, head to toe exam for any head and neck cancers, squamous lesion, etc. And we may need to refer the patient to the gynecologist, to the urologist, to the dermatologist. Diagnosis is made, as we know, on cytology, but we need biopsy to confirm. Formal biopsy can be done with conventional anoscope or by the high resolution anoscope. Actually, digital rectal exam for the diagnosis has a very low sensitivity. anoscopy, we have actually in anal intraepithelial neoplasia, we can find macroscopic area of anal intraepithelial neoplasia. Okay, if during our screening we find during the cytological screening we find low squamous or high squamous intraepithelial neoplasia, we should go for formal biopsy, either with conventional anoscope or by the high resolution anoscope. Of course, if we are using the high resolution anoscopy, we should focus on the transition zone, the zone where the carcinogenic cell will appear. They talk about the high resolution anoscope. As we discussed, we already see a picture. It is an office procedure. Patient is put in the right or left position. No anesthesia or power prep is needed. We have two techniques to search to diagnose intraepithelial neoplasia during anoscope, traditional, conventional, or with the high resolution. Either to put acetic acid, 30% acetic acid for 3 to 5 minutes. This will magnify, this actually will the region will appear white, called acetowhitening, and the lesion, and also the high resolution endoscopy will magnify the field. Or another solution, we can use iodine based local solution. It is not advisable because it will not differentiate between the degree of anal intraepithelial neoplasia. Actually, iodine local solution, the only normal tissue will absorb it, the dysplastic tissue will not absorb it. Okay, before moving to the treatment, I will show you, this is the anoscope. We already see it before. We can use for diagnosis acetic acid, or we can use local solution. We prefer acetic acid, and we look to many things in anoscope. I will just bring for you this picture. High resolution anoscope, we look for A, B, C, and V. The acetowhitening lesion, the lesion will become white. The border, the contour, the vascular changes in the lesion. This is how the anoscope high resolution looks like. We said high grade, low grade, we need tissue biopsy to confirm the diagnosis. Okay, let's move to the treatment. Okay, how to treat anal intraepithelial neoplasia before developing to squamous cell carcinoma. Actually, unfortunately, we have variability in the guideline. Often we depends on the expert opinion and the surgeon opinion, and this is low level of evidence, as we know. Actually, this is guided by the grade of the anal intraepithelial neoplasia, by the immune status of the patient, and etc. We have many options, as you see in front of you. Of them is the observation. We can follow the patient with expectant management or observation. We can observe this patient after confirming that the patient is having anal intraepithelial neoplasia, especially in grade 1 or low grade intraepithelial squamous lesion. We can observe this patient either with cytology, with biopsy, with traditional endoscopy, with high resolution endoscopy. It doesn't matter the regimen itself. The matter is the adherence of the patient to the follow-up. Again, this is advised only in anal intraepithelial neoplasia grade 1, or in another word, low grade squamous cell lesion. Okay, this is regarding the expected management. We have the other modalities, the topical agent such as imiquimod 5 fluorouracil. We have another modality is the ablation. Ablation can be either fulguration, can be infrared coagulation, or wide local excision. It is an old-fashioned that remove all tissue. Yes, it is of a good cure and low recurrence, but it remove all the tissue. It can cause stenosis, as we will see. Again, let's just see this picture, that observation or expectant management based on that low-grade dysplasia rarely developed to squamous cell carcinoma. It doesn't matter what to use in your surveillance, it matters the patient adherence. The typical therapy that we know is that, as we see, trichloroacetic acid, 5 fluorouracil. These are typical therapy, cidofovir and imiguamod. These are the typical agents. Local ablation can be with fulguration, with electrocautery, or excision, wide local excision, or infrared coagulation. And wide local excision, actually, this is an old-fashioned, remove all healthy tissue and can result in stenosis and or incontinence. So it's not used nowadays as a modality of treatment for intraepithelial neoplasia. If we want to talk in details about the typical agent, just a minute, let's go back. Okay, the typical therapies. Okay, the typical therapies, it could be trichloroacetic acid. This is the trichloroacetic acid. This is the 5 fluorouracil. This is the cidofovir. Actually, and imiguamod 5%. Okay. As you see in this picture, this is the typical therapy. It's actually used for low or high grade squamous intraepithelial neoplasia. Actually, when local ablation is not tolerated by the patient, or as a adjunct to local ablation. So we said either expectant management, conservative, or local ablation. The typical therapy is an adjunct or adjunct to local ablation, or those who cannot tolerate local ablation. Trichloroacetic acid is well tolerated, can be used as a single or multiple uses. It's good for men who have less than 3 lesions. Most topical therapies have a side effect in a form of skin reaction, but they improve with moderate analgesia and bath. Fluorouracil, it have disadvantage: burning, pain, low cure rate, high recurrence after stopping. Cidofovir is the same. Imiguamod have many regimen, 5%. For 4 months, every 3 weeks, minimal pain, easy to use, burning effect, also low cure rate, high recurrence after stopping. We said again, topical therapies for low grade or high grade when ablation is not tolerated, or as adjunct to ablation. Okay. Okay, what else we have? The local ablative therapy. As we said, local ablative therapy can be in many forms. Local ablative therapy: fulguration with electrocautery or excision, or infrared coagulation by the high resolution anoscopy. Actually, these are, with the analgesia, these are an office based procedure. These are the treatment of choice for anal epithelial neoplasia grade 2 and 3. Okay, no negative margin required. I will show you this picture. We said that anal intraepithelial neoplasia grade 1, we can follow this patient with expectant management, anal epithelial neoplasia grade 2 and 3, ablation. Whatever the type of ablation, fulguration or coagulation, etc. The topical agent actually as adjunct to ablation, or when ablation is not tolerated. Okay, the wide local excision, actually it is, as we said, where is it? Wide local excision, sorry. No. Okay. Local ablation. This is the wide local excision. It is historically the mainstay treatment. It removes all tissue, even healthy tissue, and can result in stenosis and incontinence. Now it's withdrawn as a treatment for anal intraepithelial neoplasia. Okay. We come back, you can see here that no wide local excision is here, either ablation or expectant management. Okay, what else we say? We want to, okay, regarding the surveillance and prevention, this is actually the surveillance. We have to remember that all modalities of treatment carries a recurrence rate, and our surveillance depends on the immune status of the patient, the risk factor the patient have. We said that grade 1, we conservatively manage it. Expectant, not conservative, expectant management, we observe the patient only. But for example, if the patient is immunocompetent, we do cytology and high resolution anoscopy for 2 years. If it's normal, so annual cytology is enough. While if the patient is a high risk with past medical history, immunosuppressed, so we need high resolution anoscopy every 6 to 12 months plus annual cytology. So in another word, I know that the information is heavy a little bit. In another word, if the patient carries risk factor or immunocompressed, the surveillance program should be more intense. That is it. Also in ablation, in intraepithelial neoplasia type 2 and 3, even surveillance in immunosuppressed patient is more intense, and even high resolution anoscopy should be repeated every 3 to 4 months, and annual cytology. Yes, regression can be noted. You can see here that regression from anal intraepithelial neoplasia 2 to 1 can be happened, and we go to more lesser attenuated regimen of follow-up. Prevention, it is clear that a human papilloma virus quadrivalent vaccine decrease the incidence of anal intraepithelial neoplasia. Also, that decrease the incidence of genitalia, genitalial lesion, especially in men who have HIV and have sex with men. It doesn't matter how to, again, it doesn't matter how to do your follow-up or your surveillance with cytology, with high resolution anoscopy, with biopsy. The matter is the patient adherence or the patient compliance to your follow-up. What else I can add regarding the surveillance? Thank you. We have reached the end of our lecture. Bye bye.